happy Tate Meyer, and welcome to an introduction to precision neuromuscular therapy for the lower extremity. I have to say that working with the lower extremity has always been my favorite area to treat. I think this goes back to my earlier practice as an athletic trainer and working primarily with athletes. Nearly every sport has some kind of impact on the lower extremity, whether it's on the grass, on the turf, on the courts, on the mat, even in the water. We see a condition called swimmer's knee that can be common in those that swim breaststroke and utilize a lot of the whip kick. As a neuromuscular therapist, I continue to work with athletes or the active individuals, the active adults, particularly the older athlete. That age group between approximately 30 and 70. I have found that this is a very needy group as more and more people are becoming active and staying active into their mid and later years. In this seminar, PNMT for the lower extremity, we will start with the hip and methodically work our way down from the hip to the thigh, to the knee, to the lower leg and foot, all the way down to the little toe. Each area is thoroughly and precisely addressed, first by lecture and anatomy review, then by hands-on demonstration and hands-on treatment. This is a workshop environment, therefore your interaction is key as a majority of it is hands-on. In this seminar, as in all PNMT seminars, we de-emphasize textbook treatment. I have this issue, I'm going to treat it this way. It is just not that simple. We teach you to use your clinical reasoning and problem-solving skills to address each and every individual. No two are exactly alike. One symptom could be indicative of a number of issues. I have hip pain. Is it joint? Is it fascia? Is it muscular? Is it nerve entrapment? Is it trigger point referral? It could be a number of things, and we use our deductive skills and teach you to use yours to sort that out. Let's take the hip for example. The hip is a very active area. The hip can refer up, the hip can refer down. Let's take an example of a client who presents with referral pain down the leg. First and foremost, we must rule out other pathology that could be out of the scope of our practice. With a thorough history from the client, brief treatment and simple tests, we can determine whether or not it is appropriate for us to treat or to refer them to another medical practitioner. Once we have determined that it is safe and appropriate for us to treat, then we must use those deductive skills to sort out where is this referral pain coming from. It could be coming from the piriformis, which can commonly refer pain down the back of the leg. It could be coming from the glute medius or minimus, which can refer pain all the way down the leg, either laterally or posteriorly. It could be coming from ligamentous, the sacrotuberous ligament. By meticulously assessing and treating, our goal is to determine the cause of pain and reduce the symptoms, and eventually provide great results and hopefully total release and permanent relief of symptoms. Another example is knee pain. Again, by the client's history and our assessment, we first rule out possible orthopedic injury, such as ligamentous tear, meniscus tear, degenerative joint disease. Lateral knee pain could mean a lateral meniscus tear, or it could be something which we can successfully treat, such as iliotibial band friction syndrome, or ITBFS. Medial knee pain could mean a medial collateral ligament sprain, could be a medial meniscus tear or degenerative joint disease, or it could be Pez-Anzurine tendinitis, or pain coming from the medial hamstring, especially the semimembranosus, which can mimic medial meniscus pain. Lastly, an example of foot pain, plantar fasciitis. Plantar fasciitis can be very painful and debilitating. One of the most common and successful treatments for plantar fasciitis is stretching the heel cord, the gastrocnemius. But what if the pain is coming from nerve entrapment? What if, for example, the plantar nerve is entrapped? Well, nerves don't like to be stretched. Nerves are designed to slide back and forth in the houses that they live in. If we take an entrapped nerve and stretch it, we are quite likely to increase the symptoms, prolong the recovery process, and cause more pain. So determining whether it's fascia, muscular, or nerve is critical, as each is treated very differently. In PNMT for the lower extremity, these examples are just a fraction of all that will be presented to you. You have the option of taking a 19-hour, 2.5-day seminar that covers everything from the hip to the foot, or you can break it down into two 1-day, 8-hour seminars, one being the hip and the thigh, and the other the lower leg and foot. I hope you find this seminar insightful and educational, and ultimately get great satisfaction from working with clients with lower extremity issues, as I do. And I thank you.